Hey, welcome to the Institute of Medicine Chicago. Hello, my name is Courtney Avery. I am a member of the Board of Governors of the Institute of Medicine. In addition, I am a senior consultant with Colleton, Boyer and Luce, a boutique public affairs firm specializing in corporate reputation, issues management, and crisis communications. We are extremely delighted that you are here with us today to discuss homelessness and its impact on the individual. However, the community at large and the community at large. During the pandemic, 10% of beds were cut for the homeless, only adding that already present challenge impacting all of our communities. We will explore ideas and solutions that are working both on the national level, but also on a regional level. Today's speakers are experts and committed to this issue with pragmatic experience. As we stated in our previous 2022 session, IMOC is focused on real world solutions. We are involved, support, and open to research and studies, and we want to discuss ideas and opportunities that have a positive impact on supporting individuals and communities. Today's agenda includes a panel discussion, questions and answers, period, and updates on the future programs and speakers. Today's learning objectives are to identify why homelessness is not seen as a public health issue, gather an overview of homelessness during COVID nationally and locally, obtain an update on community view of homelessness in Chicago, and relate to case studies that identify current solutions and centers that are working successfully. Pictured now is our Board of Governors for 2021 through 2022. And on behalf of the Board of Governors, it is my pleasure to warmly welcome everyone today. We are honored with your overall support of IMOC. If you are visiting us for the first time, we conduct monthly virtual sessions, except during the summer months of July and August. There are numerous opportunities to be engaged with IMOC. In the fall, we expect to begin our work groups. Please stay tuned for more information. The Institute of Medicine is an independent, nonprofit organization of distinguished leaders in the health field who collaborate to improve the health of the public. Drawing upon the expert of a diverse membership and other regional leaders, the IMOC addresses critical health issues through a range of interdisciplinary approaches, including education, research, communication of trusted information, and community engagement. Our upcoming events, before I want to share with you for our fall calendar. On April 1st, 8th, and 29th, IMOC is partnering with Rosalind Franklin University with intersectionality of education and community engagement. On May 6th, we are addressing chronic kidney disease and its disparities. June 30th, 2022 is our annual meeting and awards ceremony. We hope you can join us. It is important to note that the April program will be hosted by the Institute of Medicine with Rosalind Franklin. There will be 4 virtual sessions addressing the intersectionality of education and community related to healthcare, trends, and careers. This special series would include about 20 speakers. Overall, RFU is addressing health equity through community engagement, education, outreach, and partnership. On June 30th, we will host the annual meeting at the venue 610. This is a new date, so update your Outlook calendars if you have already been planning to attend. We're planning an in-person event at the venue 610. And again, please save the date on your calendars. The 2022 IMOC Healthcare Awards are open for nominations now. There are 7 award opportunities. The deadlines are May 2nd through the 4th for award types. And please consider nominating a colleague or an organization this year. The awards will be presented at the annual meeting. Last year, we honored the public. Last year we honored public health directors of the 6 Collier counties with the Special Public Service Award. We continue to support their efforts and commitment with continuing challenges of COVID-19 and other issues. Their role is very important to their communities as it touches mental health, safety, health, disease, and prevention, and more. And I want to go back to the date. The date will be the 24th of June for the annual meeting. Now, today, I am pleased and excited to introduce our speakers. Like myself, they have over 15 years in the healthcare, public health policy, and serving in our community space, especially servicing our communities. All 3 of them are excellent in that. We will begin with Representative LaShawn Ford. Representative Ford has served since January 2007 on numerous assignments. His present committee's assignments includes appropriations for higher education, where he's the chair, financial institutions, personnel and pensions, public utilities, miscellaneous issue subcommittees, special subcommittees, and he is also the chair of the Democratic Task Force to increase state government business and the opportunities for minority-owned enterprises and small businesses. He also chairs the Firearm Public Awareness Task Force and the co-founder of the West Side Heroin Task Force. In 2018, Representative Ford received the Nelson Mandela Award for Justice Honoree from the West Side Health Authority. This award was in recognition of his tireless service and outstanding contributions in fostering peace and fighting for justice on the West Side of Chicago. Our next speaker will be Joel Siegel. Mr. Siegel is in the National Campaign Director of the Bring America Home campaign, a national campaign to end homelessness and unemployment for the homeless. That is being spearheaded by the National Coalition for the Homeless out of Washington, D.C. He is a former board member of the National Coalition for the Homeless also. Mr. Siegel received his undergraduate and law degrees from the University of North Carolina, Chapel Hill in 1985 and 1989. Joel is a senior fellow at the George Mason University Center for World Religion, Diplomacy, and Conflict Resolution, and is a visiting lecturer at the University of California, Washington, D.C. Our third speaker will be Nellie Vasquez Rowland, who is an influential force in Chicago, that's an understatement, and a social entrepreneur, author, speaker, and subject matter expert on the topics of homelessness and the opioid epidemic in America. In 1984, Nellie and her husband, Brian Rowland, a military veteran, left their successful 13-year careers in finance to launch the Chicago Profit, elegant solution to end homelessness known as a Safe Haven Foundation. With investments from their own pockets, they formed an organization and lauded today as the pioneer architects for one of the most innovative social service models in the world to help break the cycle of addiction, homelessness, incarceration, and unemployment. At this time, I would like to present to you Representative LaShawn Ford.
Thank you very much for your introductions, and it's such an honor to be on this panel, the IMOC's panel, Courtney, and to be on the panel with you and Nellie and Joel. I think every day we should be talking about a way to end homelessness in America, and especially right here in Illinois and Chicago. The title being homelessness is a public health and healthcare issue. It surely is, and it is also a public health crisis in America that we can fix. Studies show that people living on the streets die at least 10 times the rate of the general population. People living in a shelter die at 3 times the rate of the general population. A child who is homeless for only 6 months has poor health and development delays. Housing decreased hospitalization by 29% per a study done by the Cook County Hospital 14 years ago. And if people are housed and receive the needed support, their health improves in the same study. And so I'm very honored to be on this panel with people that not only understand the problem, but they understand how to get to solutions. And so Nellie, I've been working with Nellie on this issue. In fact, during the pandemic, Nellie and I and another member of the community held town halls virtually every, I can't remember, we did it every day. Was it every day? But it was amazing that we were able to continue to raise the awareness. And so my charge is people should join organizations like the IMOC and maybe join organizations to make sure that we do something about helping people that's experiencing homelessness or on the brink of homelessness. And Nellie understands, like everyone on this panel, understand exactly that it's a problem that we can fix, but we have to do it structurally. And so I'm very happy to have worked with Nellie on a bill, House Bill 3949. And what the bill did, it passed the House. It's been supported by the Department of Public Health, the Department of Human Services. And as a provider, Nellie realized that A Safe Haven was left out of the funds for the federal relief for homeless providers. And so she crafted a bill, Illinois House Bill 3949, adding homeless providers to become a part of the Illinois public health critical infrastructure. And what that is going to do when the governor signs it, it amends the Department of Public Health powers and duties and laws of the Civil Administrative Code in Illinois. And it defines homelessness and homeless service providers to mean a person or entity who provides service to homeless persons under any of the programs of or identified by the Department of Human Services. It requires the Department of Public Health to consider all homeless service providers in the state to be essential critical infrastructure workers under a specific guidance from the government. And so that bill right now is in the Senate, awaiting the passage in the Senate. At this time, we have a commitment from the Senate sponsor that he will get the bill across the finish line. Also in Springfield, we worked on a bill to help prevent people from homelessness by sponsoring and passing House Bill 2775. And the purpose of 2775 is to make it easier for low-income families to find housing. The bill amends various acts to reflect that purpose, and it simply defines source of income and provide that it is a civil right violation for any person engaging in real estate transactions to discriminate based on source of income. And so we believe that people that are on fixed incomes, whether it's Section 8 or Social Security, these are women and men that have fought for our country, and they should not be shut out of housing opportunities. So that bill right now is in the Senate waiting on the passage. And also, I want to give a report that the Illinois Housing Assistance Fund will begin to take applications in April for home owners. And there will be grants up to $30,000 to eliminate or reduce past due mortgages and property tax payments. So you should be on the lookout for that. And the Illinois Department of Human Services will also help those that are struggling with rent. So for those who missed the window to apply for the round of assistance through IDA, that's the Illinois Housing Development Authority, the Illinois Department of Human Service, Secretary Ho is going to be accepting applications for up to $25,000 in rental assistance on a rolling basis. The Illinois Assistance program. And so for people that's looking for assistance for housing in Chicago, you should call 311. And for those that want assistance from the state, not just in Chicago, but throughout the state of Illinois, please call the Illinois Department of Housing Development Authority, and they could be reached at 1-855-631-0811. Thank you so very much, and I encourage everyone to find a way to help change the structure problem that we have causing people to be homeless or on the brink of homelessness. Thank you so very much, and I look forward to the presentations from the panelists.
Thank you, Representative Ford. We appreciate your commitment to this important topic, and your sincere concern for the homelessness is really showing. Your connectivity to achieving health equity, we also appreciate. We want to focus on the social determinants of health to offer the highest quality of life to individuals, not only in our immediate families and in our communities, but worldwide. Now, thank you again. Now I would like to invite Joel Siegel to present his insights and experience on the national level of homelessness. With his experience in policymaking, he brings another level of expertise to how to think differently about homelessness, its impact, and how to rethink it. Mr. Siegel, please proceed.
Hi, everyone. Good afternoon. Representative Ford, what an honor to be with you and my distinguished group of panelists. Thank you, IOMC, for inviting me to speak at this event. I want to say that the Institute of Medicine saved my life many times. I worked on the Hill for many years, and for the late, great Representative John Conyers. And whenever I was a speechwriter and legislative director, and if I needed talking points to talk about, I was the lead staffer on the Affordable Care Act, known as Obamacare. But I always would use Institute of Medicine data to be taken seriously. So I want to thank you for saving my job on multiple occasions. And then I'm going to have to love up Nellie Vasquez. She was the most effective lobbyist and advocate that I've ever encountered in my 13 years in working in Congress. She was always there, very passionate, advocating for the unhoused, people who need mental health services. So Nellie, I'm glad we've reconnected after all these years. So I want to say that I ran shelters for about 5 years. I ran emergency shelters. And on my first night, I realized that the majority of the people who had come into the shelters were working people, men who would come in with hard hats and tools. I didn't know that. When some of the men would get sick and go to the hospital, they would be turned down. I live in North Carolina now, and I did run shelters in Charlotte, North Carolina. They would be turned down from the hospitals for emergency care. And I used to have to teach my clients to have the flu. In the richest country in the world, you should not have to do that. There should be, universal health care and the dignity of when you get sick, you should be able to see a doctor whenever you need care. It was very upsetting to see that situation. Also, what I see as someone who's been in this field for over 30 years is a systems failure. I'm a good government activist. I've been in government almost my entire career, and I believe in good government. I don't believe in partisanship. I believe in problem solving. The systems breakdown are in the following areas. We have millions who lack affordable housing, inexcusable in the richest country in the world. Both parties have failed their obligation to provide safe, decent, affordable housing for every person in America who needs affordable housing. We have a systems breakdown in healthcare. We have a system where there's millions who are still uninsured, even after the passage of the Affordable Care Act. Every other country in the industrialized world has achieved universal health care. I was the author of the bill Medicare for All, and the doctors I worked with were mostly from Chicago and Harvard Medical School. We can do better. Everyone should have quality, affordable health care, and the Affordable Care Act passage was a step in the right direction. We got to do better. We also have a systems failure in mental health. Too many people who access the mental health system go to get treatment for bipolar or schizophrenia or other disorders. And when they are treated successfully, are dumped into the streets with nowhere to go. As a man of faith, as a Jewish person, I find this to be a sin against God. You don't take the most vulnerable citizens who are poor, often of color, often African-American, and dump them into the streets or to a homeless shelter. We can do better. Drug and alcohol treatment is another system's failure. All too often, many of the men that I would talk to and urge them to get care at a drug and alcohol treatment facility would get a 30-day program, not long enough if you need more restructuring. Sometimes you need 6 months to a year. Where I live in Charlotte, North Carolina, the men would go into the treatment center because I would go there with them. There was no chairs, but there were cigarette butts, and they would sit on the floor. That's not right. The other failure is children. How in the world did we become a nation with over 1.3 million homeless children? Every study that's been done on homeless children has shown permanent trauma and cognitive delays. Where I live, we have schools for children. That's homeless apartheid. That doesn't make any sense. Food and hunger is the other system's breakdown. I've recently written legislation to end hunger. I wrote it with professors from Howard University. In the richest country in the world, we can solve hunger by feeding people nutritious food and taking the time to do so. In Tent City in Charlotte, North Carolina, most of the people did not have access to healthy food. In fact, a lot of the food was on the floor and on the ground, and it was not healthy food. Often people who are homeless don't have access to the social services to get food stamps because there are no public service announcements letting them know how to access coordinated services. The other problem is unemployment. We need a system where anyone who wants a job in America can get a job. The stresses of being unemployed, I think if anyone's been unemployed, I know I have, it creates such stress on your colon and your whole system. We need a jobs for all program. I've written a bill, Jobs for All, that when I was with John Conyers, soon to be reintroduced, I hope, by a Chicago member of Congress. Let's not forget Roosevelt. Roosevelt created a jobs program for millions of people. Doesn't it make sense to maybe study Roosevelt or even Nixon's CETA program, where the private sector would hire people and pay their salary for 1 year? We need to look at eviction prevention. It doesn't make sense to evict a family from their home or their apartment when we can do what's done in France and every other country in the world, provide them a pathway to self-sufficiency where their rent is paid for a temporary period of time, and then they are provided job training and job placement. Eviction prevention is very, very costly, and we can do better. In Philadelphia, they have an eviction prevention court, which is something I think that we need to study. What's the Bring America Home Now campaign? It is a campaign out of Washington, D.C. I'm proud to be the national director of the campaign. Our goal is very simple: end homelessness once and for all. Can we do it? Absolutely. But we can't do it unless we have the participation of the mental health and the medical community. Homelessness is a healthcare crisis, and we must be fierce about that advocacy. Life is short. Let's give everyone the opportunity to enjoy the American dream, to enjoy living a middle-class life. We need ladders of opportunity. We need healthcare to be universal. I'll close by saying that with the Institute of Medicine weighing in on this issue, can take homelessness to a whole nother realm of importance. Why is that? Having worked in Congress for 13 years and lobbied there for 14, I can tell you that when doctors, mental health experts, homeless experts, those working in the field of mental health, drug and alcohol treatment come into Congress, you have immediate respect by the staff and by the members, Nellie Vasquez being a very good example of that. I could go on about Nellie because everything I'm saying, is very, very true. Once again, I want to thank the Institute of Medicine. I'll close by saying that we've got a dream, and we can't forget Martin Luther King. Martin Luther King used to say, I have a dream. We need to have a dream. Everyone should have housing, healthcare, a job, and live a life of dignity. and self-respect. We can do that. It's called democracy. Let's get engaged in our democracy and address these systems' failure. We got to do it with the public, private sector, interfaith leaders, artists, small business. That's what the Bring America Home campaign is doing. We're advocating right now for 2 bills. One is Maxine Waters' bill, which would provide 500,000 housing vouchers to homeless people. The other, AOC's bill, which would repeal the Faircloth Amendment, which bans all public funding for public housing. Anyway, I'm so honored to be here. Thank you very much for giving me an opportunity to speak to you today.
So again, thank you for your insights and your perspectives. Now I would like to introduce my fellow board member, President and CEO of the Safe Haven Foundation, Mrs. Nellie Vasquez Rollin.
Hi, everyone. Welcome to this amazing, amazing forum where for the first time, we're actually able to discuss the issue of homelessness being a public health care issue. And I'm so honored to be on a panel with individuals that have worked hard throughout the years, I mean, since they've started their careers on this issue alongside with us here at A Safe Haven. We could not have done the work that we do without their support and their willingness to champion so many of the things that we've been working on the front lines with those in need. So just again, a little background on myself, you know, my husband and I, you know, went through a journey of overcoming substance abuse and poverty issues in our own lives. And, you know, we were able to, you know, break glass ceilings and go into careers and thankfully build, you know, a life, you know, that most of us would have, you know, been so grateful to be on a path that, you know, really supported a lifestyle that we never could have imagined. But back in 1994, we could not help but notice that many of the well-intended laws that were being passed were really draconian against the most vulnerable populations. So many of you may recall the crimes bill, which really, you know, treated substance abuse, which is one of the leading causes of homelessness, as a moral criminal issue that was going to lead to people with the least amount of resources to do time in prison, which led to what they call today mass incarceration. So knowing that there were incentives to help states across the country build more prisons to fill up that pipeline of people that were being impacted with substance abuse issues, we knew that this wasn't something we can, you know, be bystanders on. Having gone through it ourselves, we knew that, you know, the system, well intended, was, you know, definitely not the way to treat someone that the World Health Organization has actually deemed the issue of substance abuse, for example, as a disease. And so, you know, since then, you know, we started on this path of really trying to offer an alternative. And today we're super proud to share with you a model that we have built over the last 27 years that has truly been there for over 135,000 people throughout the years, get access to many of the issues that Representative LaShawn Ford mentioned, and many of the issues that Joel Siegel mentioned in terms of, you know, where the gaps are and where the systems have failed, again, the least among us. So yes, housing is healthcare. We trademarked that term back in 2004, and we're so you know, excited to see that it's resonating today. And the next step is defining the issue of homelessness as a public health issue, and we'll share with you why that matters. As both Representative Ford and Joel Siegel have so eloquently described, you know, there's millions of people across the country, hundreds of thousands of children that are ending up homeless. And that was because they're fleeing domestic violence issues, their parents are incarcerated, addiction issues are present, their physical issues, you know, medical expenses, believe it or not, are a leading cause to the catastrophic consequences that lead to homelessness. I mean, the list goes on. The barriers that are created for people that are facing homelessness to education, to food, to jobs, means that these issues become oftentimes generational. And today we have a once in a lifetime opportunity to reimagine what that delivery system looks like. and support what I believe could be the delivery system of the future. And we hope that our work at A Safe Haven will help, inform decision makers on what that new delivery system might look like. As Representative Ford described, the public health infrastructure became painfully relevant during the time of the pandemic. And I say painfully because of the fact that while we were, as a government, being very intentional of making sure that we were shoring up resources to those that were going to be the first responders, to the essential workers, to the essential organizations that people in crisis were going to rely on in response to the pandemic. We were super happy to see that hospitals, healthcare providers, clinics, nursing homes, and assisted living providers were at the top of the list of organizations that got financial resource support, that got the PPE supplies, and even were first in line for the vaccines. But we were very surprised to find out that although homeless providers were also on the front lines working with the most vulnerable populations during this time, we were not included as part of that critical infrastructure, and we were not included as far as being part of the baked in team that was going to qualify for the emergency funds. While at the same time, we were facing financial challenges, higher demand for services, increasing costs due to inflation, due to wage increases, especially with the increase of the minimum wage, and higher risks in terms of health risks, and again, responsibilities with the shelter in place. It was lost on many that homeless organizations were taking on the responsibility even for taking in these children that normally would be going to school that are in our care. In our case, at A Safe Haven, that meant that we had over 1,200 people that we were responsible for in a way that was even more urgent than ever before. I want to just explain a little bit to everyone in terms of what the cost is for healthcare, specifically for people that are facing behavioral health care issues and homeless diagnosis, for example. In 2016, it was identified that the state of Illinois had 3.2 million individuals that were members of Medicaid. Of that population, 25% or 800,000 individuals were actually diagnosed with behavioral health care issues. Do you know that they account for 56% of our Medicaid spending? And that is, as Joel Siegel described, they're the super utilizers. They're the ones that are really utilizing the healthcare system. And once they're released and discharged, they have nowhere to go. Oftentimes, hospitals are forced to keep people in healthcare systems longer than they should. And they're also releasing them oftentimes to dangerous situations, a home environment that's not conducive to recovery, or where they're very likely to relapse and re-enter the healthcare system. I did a report back in 2010 that I submitted to the state to bring this information to the attention of the state that showed the average homeless individual, especially those with substance abuse issues, utilize the emergency room an average of 6 times a year. We'll talk more about how we can change that system. In Illinois, the state budget during that time, from 2010 to 2015, went up from 23.6% of our state budget to 27.6%. In total, in 2016, the Medicaid budget has a state-federal one-to-one match. So for every dollar the state spends for Medicaid, for example, the federal government matches that. So our total state budget is about $19 billion. Of that $19 billion, again, in the Medicaid system, if 56% of the cost is due to the super utilizers or those that are diagnosed with behavioral health care issues, then that means that of our $19 billion, we're spending $10.8 billion on dealing with the individuals that are suffering from underlying issues, such as behavioral health care issues, not necessarily healthcare, but behavioral health care. Also, what would it mean that if we were to reduce the cost of the behavioral health care piece to the Medicaid system just by 2%, that would mean that our state could save over $216 million. I believe by influencing a better paradigm that allows people to move out of the healthcare system and be immediately discharged to a more conducive level of care in the community, transitional housing, community-based behavioral healthcare, state licensed organizations, that we can accomplish that goal of at least reducing the cost to the behavioral healthcare system or the Medicaid system by at least 2%. Next slide. Another example, an estimated number of people in the Illinois state prison system in 2017 that were diagnosed with mental health issues amounted to about 7,800 individuals. They too are costing our state over $253 million. Imagine if we took these individuals out of the state prison system and were able to get them into a model that was going to address the underlying behavioral healthcare and mental health system issues that they're dealing with, then ultimately we can reduce the cost to our criminal justice system, to our state as well. So in total, if you were to combine the cost of what we're spending as a state with healthcare, behavioral healthcare, and prison economic burden to the state, we're spending currently over $469 million of costs that can be spent in a way that's going to not only address their underlying conditions, but ideally help mainstream them into jobs and permanent housing and ultimately break that cycle. The reason I wanted to show this slide is because I wanted to show our viewers here today that if we were to really treat homelessness in our city, in our state as a priority, would our budget be $26 million? There are over 100 homeless providers in the state of Illinois. If you divide the 100 homeless providers in the state of Illinois by 20 with the $26 million, that means that each organization is getting, if they're lucky, a total of $260,000 to deal with an issue that represents over 100,000 individuals that are in need. Currently, the federal government, through the point in time count, says we have 5,000 homeless individuals in the city of Chicago. If you look at a report that was done by ABC in July, I believe it was 2015, that number is closer to over 150,000 individuals. I say it's somewhere in the middle, because even if you look at CPS, the Chicago Public School System, they've actually documented over 16,000 homeless children in the school system. So it is something that we all should be aware of. And as constituents and as voters, we should consider how can the state best spend our resources when ultimately those 5,000 individuals that are documented, we know the number is higher, account for a high number of individuals that are super utilizers in our healthcare system, and also are the victims of being arrested for crimes they commit due to the fact that they're under the influence or desperate for food. Alternatively, I didn't make a slide on this, but if you look at our city budget on what we spend on policing, I believe that number is about $1.6 billion. So clearly the issue of addressing homelessness is dwarfed by many of the other ways that we address many of the issues that our city is facing with our most vulnerable populations. So here's what we learned during the pandemic. Again, we found out that we were part of the critical infrastructure, but we also have heard many elected officials and leaders in our city and state and people across the country identify and refer to homelessness as a public health issue. To my knowledge, the city of Los Angeles is the only city in the country that has actually declared it a public health emergency. In the meantime, we are not part of the official public health infrastructure, and that's where Representative and I got together and we were able to write a bill that hopefully some of the lessons learned during the pandemic is the priority to elevate homelessness and homeless organizations to become a part of their public health infrastructure. Next slide. So here's another example of what the delivery system looks like today. We talked about how hospitals, detox, healthcare clinics, people that are getting diagnosed with behavioral healthcare issues, we know all this information. Currently, the system does not allow hospitals or detox centers or healthcare clinics to refer people to another level of care that is funded, because the funding does not match. So for public and private health insurance, these part of the public health infrastructure, hospitals, detox centers, health clinics are funded. But when it comes to referring people to a level of care that is also funded, it's non-existent. So unfunded discharge options that hospitals have oftentimes, regrettably, are to send people back to unstable living conditions, unsafe living conditions, homeless shelters with very little resources, or to the streets. The challenges for the patients at the end of the day, they have a high risk of medical non-compliance, high risk of relapse, and a high risk of death. Next slide. What we're proposing with the idea of HB 3949 and another bill I'll talk more about at 5403 is the fact that with private and public health insurance, let's continue to pay for the emergency healthcare system, but let's add public and private coverage to include discharge options, which include community-based medical respite, which is something that we were able to prove, do a proof of concept with the COVID-19 medical respite at a safe haven, which we don't have time to talk about, but that was an excellent case study of how hospitals were able to refer people to a step-down program with people that were suffering from other social determinants of health and care issues, and also being able to discharge them to transitional housing that again provides wraparound services. Here's the upside: improved outcomes. We have better medical compliance, better access to stable housing, assessment-driven services, reduction in hospital readmission rates, improve overall healthcare outcomes, reduction in the costs, and improve all the social determinants of health that we are all anxious to deal with to, again, stabilize individuals as well as their families. Next slide. So how do we change that current paradigm and move into a new, more influential, comprehensive, and integrated system? For the first time in history, we have two bills that are perfectly paired. The definition of homelessness as a public health issue, HB 3949, we're super proud of our champion and sponsor, Rep. Ford. He brought it through the finish line with 100% support. Today, it's in the Senate. It's being sponsored by Tony Munoz, and we are waiting to hear back. I know they've made some even more amendments that have made this bill even better. So we can't wait to hear back in terms of what that looks like. And how do people get involved? You call your senator and you ask them to please pass this bill. The next bill that we've been very excited about is HB 5403. That bill actually allows us to go back and enforce a 1115 Medicaid waiver that was approved by the federal government for the state of Illinois to use this Medicaid money differently and allow it to expand payment to community-based providers. So this is not being voted on right now in the House, but my understanding is it might pass under the omnibus bill. Again, it does require support from the public. These two bills will allow us to, again, have the definition and have the funding stream. That Medicaid waiver was a 5-year demonstration project. My hope is that we can ask for an extension. And the goal of that bill, when it was originally introduced, was for the state to allocate $2 billion to that bill that will be federally matched to pay for this concept or this demonstration project, but also with the goal that it will either be budget neutral, which means it shouldn't cost us any more than what we're already spending, but ideally with the goal of reducing our cost by 2%, which again translates to over $200 million for our state. Again, the transitional from a federal level, Joel and I have been talking about this. We believe that the Department of Housing should reinstate funding for transitional housing, which is not included from a federal funding perspective, to expand capacity. We are seeing pent-up demand. And as was described by Courtney in the beginning of this conversation, there has been a shrinkage of homeless beds in the country as the pandemic forced many homeless organizations to close or to decompress, because the idea of spreading COVID-19 in a congregate setting was a very high risk proposition. So I think that's all I have. Is there another slide? Okay, that's it. So thank you all for allowing us to give this presentation. I hope that what we presented here today was a great explanation from a federal level, from a state level, from a frontline perspective, in terms of, again, the unique opportunity that we have right now to really help influence a paradigm shift that literally should be led by data in terms of where are we getting the best outcomes and where are we able to save money, ultimately using much of this ARP money that we are getting in every single state right now to not only build capacity, but build capacity for what's truly needed and what truly can be funded in a sustainable manner now and into the future. So thank you, IOMC, for the opportunity.
Thank you, Nellie. And we really appreciate your efforts and what you're doing on the front to combat homelessness and others who are rebuilding their lives. We really need that. We're opening it up for questions, and in the interest of time, I won't do a little recap, but there is a question. Oh, from Dr. Cheryl Whitaker. Nellie and Representative Ford, what will we do about the lack of culturally, competent behavior health companies to serve the Black communities on the south and the west sides of Chicago? Coordinate and competent behavior health companies to serve the Black communities on the south and west sides of Chicago.
Hi, this is Nellie. So one of the things that I'm just super proud of, is A Safe Haven recently won a diversity award. And from day one, our vision, was really different from what was happening out in the community at that time. So very intentionally, what we did is we were able to really look at some of the success stories in our programs and provide education and training. And about 35% of A Safe Haven's population, employees, the people that work for A Safe Haven, believe it or not, actually have backgrounds and face barriers, to employment. And many people throughout my leadership team are people with lived experience. So I think that, as we look at non-traditional workforces as being, untapped, talent, I think that, most organizations, should really look at, how could we take some of the people, even the people that we've helped throughout the years, and help them get educated and become part of the solution. And for me, that's been the winning recipe for our success, is having that perfect blend of experience, lived experience and academic, professionals to join our team.
Yeah, and I would say to that effect, the state and the city should be working to grow our own behavioral health professionals. We have the public universities where we should be offering packages for people to join the workforce as mental health providers. We have city colleges that could also help train culturally competent individuals. We have to increase the number of minorities in the behavioral health profession. We know that people feel more comfortable going to people that's culturally competent. And while we are on the path of increasing the number of people that are being trained for the profession, we have to make sure that the people that's in receive training in cultural competency. I often talk about, and it's a hot button issue, but it's true. We have to deal with the critical race theory in all professions. It sounds like a buzzword, critical race theory, but it really gets to the heart of individuals and why they struggle the way they struggle. And in order to help someone, you have to be able to feel them and understand their struggles. And that's what critical race theory could allow.
Thank you for that response. Joel, I think this will be a great question for you. What is your opinion of the Clinton Welfare to Work program that provided a wide range of assistance combined with job coaching and placement and salary support to enable people to learn job skills and then earn a living?
Great question. Very well intentioned, but in practice, I had a chance to study it when I was writing the Jobs for All bill. It really has not worked the way that it was supposed to, because it wasn't really funded at the levels that good government would entail. But it's something that we need to revisit. There's a better way to put people to work, train them. We have what's called the Job Corps, probably one of the most successful programs from the Great Society that Lyndon Baines Johnson implemented. For every $1 in the Job Corps, it was about a $7 return. I love Nellie's cost-effective analysis. She's absolutely spot on when she does that. More advocates need to do cost-benefit analysis. But CETA under Nixon was a very successful program. Under that program, a person would go to a private sector job, be paid for 1 year, or a percentage of their wage. And it was sort of like a way to get on the job training. And in Germany, probably has the best system that I've studied, where after high school, you're given an apprenticeship opportunity if you don't go to college. What we have to do is we have to reevaluate all of our jobs programs and see, Nellie, I know you can relate to this. They have to be tailored to fit the special needs of the homeless population. I ran a job training and job placement program. Many of the people that I worked with, they didn't know how to conduct a job interview. Hard to find a job when you don't have a roof over your head. So we gotta provide housing first with comprehensive services like what Nellie has been doing for years. And then, it's easier to get people trained and into the, into the job market. But there's also behaviors that people who are homeless will experience, especially those who've been incarcerated for a long time, or people with drug and alcohol treatment problems. They'll go to work and they'll curse out their boss. Well, why is that? Because it's behaviors they learn in jail or growing up. So you have to have intensive, job training skills, getting up on time. Then you got a problem with transportation. If you don't have a bus ticket, or I guess in Chicago, you have a monorail system. We don't where I live. You gotta have tickets. And there's not a coordinated system to get people housed, trained, and then to work. But the Clinton program was a good start, but it really not quite good enough to help our population that we serve. But thank you. Great question.
Thank you. Representative Ford and or Nellie, this would be a great question for you. What percentage of the Illinois Medicaid population are super utilizers, and what do we know about them?
Well, based on the presentation I just shared, I don't have a breakdown of how, what the percentage is of the super utilizer. I only have an aggregate number. And that is that 25% are diagnosed with behavioral health care issues. That 25% accounts for 56% of our cost. So to me, the first step, if you want to start to save money and save lives, is you go to that immediate, those individuals that are making up the frequent flyers. And once you understand, again, that they're being discharged to their original environment, they're not getting the aftercare, and there's coexisting conditions and complex issues that are leading to the fact that not only are they their behavior issues unstable, but they're leading to worse healthcare issues, which is why this just, becomes the spiral of cost and readmissions that happen that could have been prevented if we were able to stabilize them from a behavioral healthcare perspective and discharge them to an appropriate level of care that's going to provide them with the holistic assessment-driven services that are coordinated in a way that's going to help stabilize them from a healthcare, behavioral, education, employment, and housing perspective. And that's what we do at A Safe Haven.
Great. Representative Ford, would you like to add anything?
I think Nellie hit it. So I support Nellie's sentiment.
Great, thank you. Well, I know we have a few more minutes, like 4 minutes left. Would like to ask how we can support or let us know when those bills are in committee, especially with JCAR, and there's comment period, and when the other bills are in any committees or up for a vote, so that we can organize and get those successfully passed. Okay, I would like to personally thank you all. We just did not have enough time, and I had to remind myself that I had to listen with a different ear. So I really appreciated that, all the information that you provided. So again, the IMOC 2020 Awards, we're accepting nominations. That's due May 2nd through the 4th. So visit the website and please help to nominate. The other thing is, for today's session, we hope to see you at our next virtual session, which is on April 1st. And again, the intersection of education and engagement. Please follow IMOC on LinkedIn or check out our blogs and visit the website for more details. And again, I thank you all. We actually have about 3 minutes. So Deborah, is there anything that you wanted to add, or our speakers? Is the date correct?
Yeah, the date is correct,
30th.
June 30th. So thank you,
30th.
Courtney. Thank you, all the speakers. This has been a fabulous program, such wonderful dialogue and information, overall. It's been wonderful to work with all of you. And I know that we are looking, IOMC is looking at organizing some type of convening in order to help the Ukraine itself. And Pat Merriweather, who is one of our co-chairs for the program committee, is with Rotary International. And she has quite an effort taking place right now. And we'll be sending out some information to give some updates on that all together. So thank you everyone for your fabulous support. And thank you again for the speakers today.
And Deborah, I would be remiss if I did not thank you. I know you were pulling out your hair to get us all herded together. So I appreciate your technical support and everything that you do for IMOC.
My pleasure. Thank you very much.
And Joel, don't be afraid. Come and join us on June 30th. It'll be warm.
Thank you very much for the invite.
Have a good day, everyone. Safe
Thank
travels,
you.
Representative Ford.
Thank you.
Thank you so much.
you.
Bye-bye.